Welcome, everybody. I just want to say, first of all, I'm incredibly grateful to welcome Dr. Aimee, who I'm pretty sure you all are familiar with and also know her as the Egg Whisperer. She's a highly respected reproductive endocrinologist, and we're incredibly lucky to have her answer the questions you submitted. We received many thoughtful questions, and we'll get through as many as we can in the next 30 minutes. So let's get started, Dr. Aimee. Thank you for being here. The first question came up in different forms, so I'm going to combine it. For someone over 40 who typically retrieves 4 or fewer eggs per cycle, does a fresh transfer tend to make more sense than frozen? And based on your experience, do patients in this age group generally have better outcomes with or without PGT?
Okay, so let's start off with the first question. Should we do a fresh transfer? I think that really has a lot to do with what your priorities are. If your priority is to have the experience of doing an embryo transfer, then I think that's important to honor that experience. If what's important to you is banking embryos or making sure that you're avoiding a miscarriage, I recommend doing PGT. So for some patients, they're not given that option. And what you have to do is talk to your doctor and make sure that you have these different options, because the clinic that you go to may only give you the option of doing a freeze-all and PGT. There are some clinics that don't do fresh transfers anymore, at least here in the Bay Area. So that's how I answer that question. Would you feel bad if you find out that there's no embryo to transfer on day 5? Because I don't think you asked the question day 3 or day 5, though. So that's another part of the answer. Because if you grow embryos to day 5 over 40, there's a chance that you might not have an embryo to test or freeze. So you have to think about how you're going to feel. You have to think about, hopefully not for long, the worst case scenario. So the worst case scenario, if you grow to day 5, is you may not have anything to transfer or freeze. Would that make you feel really bad? Would you have wished you had done a day 3 transfer? If you transfer day 3 and you don't get pregnant, are you going to wonder why it didn't work? Is it more helpful for you to know more about the embryos and find out if any of them were viable? So that's how I answer that question. It's not a one-size-fits-all answer, because you have to talk to the patient and see what's really important to them and honor that from the very beginning. Because people will get mad if, let's say, you don't give them that option up front and they think that the way that the doctor is recommending is the best way, but it is not. Fresh versus frozen, the chances are going to be the same. What you're going to get from a frozen embryo transfers or in genetic testing is maybe more information, but whether you're transferring a healthy embryo early or later, if it's a healthy embryo, it's still going to hopefully stick and grow.
Perfect. A related question, which you kind of answered, but not fully for this one. When transferring a previously frozen embryo without genetic testing, is it better to thaw and transfer at day 3 or to culture to blastocysts?
Yeah, so I would just transfer it day 3, because there's a reason why you froze it at day 3 in the first place. The only reason to culture and grow to day 5 is, let's say, if you had more than one embryo and you wanted to maybe learn more about the quality of your embryos, or if you wanted to genetically test it, you could do a biopsy, freeze it, and then transfer later. But if it is your day 3 embryo that you're thinking about transferring, I don't think that, thawing it and growing out 2 days is going to be that beneficial and then transferring at day 5.
Okay, next question. I'm 34 with 1 fallopian tube blocked. Labs look fine. IVF has been recommended. Could IUI be helpful?
Absolutely. When I have a patient who has a blocked tube, I always want to know, why is it blocked? Is it possible that we're missing another diagnosis like endometriosis? Because endometriosis can also impact the health of that other tube. So when one tube is blocked, I always wonder what might be going on with that other tube as well. So with ovulation induction pills like letrozole, you can get the other side to hopefully ovulate, and you can still get pregnant without doing IVF. But if you're 34 years old, I call them my pearls, my golden rules. One of my rules is, if you're over the age of 32 and you want at least 2 kids and you don't have one already at home, really consider preserving your fertility. So if you're 34 and you're thinking, at some point I want a second baby, there's no downside to doing IVF now with your young eggs at 34. That will give you a future reassurance that you're giving yourself a better chance in the future. You can always do IVF, freeze embryos and save them for yourself, and then go back to doing ovulation induction. And I've done that with many patients where we just bank embryos now for our future pregnancy, maybe at 38 or 40. It doesn't mean that you're taking away your ability to still get pregnant as naturally as possible.
Okay, this one came up a lot as well. Thoughts on PRP? And then this person in particular, I've had 3 unsuccessful IVF cycles, 2 aneuploid blasts, and wondering if PRP could help egg quality. Also, your thoughts on PRP for someone over 40?
Yeah, so I do a lot of PRP. I have 2 sessions a month and I do about 20 cases a month. So it's 10 cases per session, just because I can't do more than that in a day. And so I have a lot of experience with it. I've been recommending it probably for about 5 years now, doing it myself probably for 3 in my practice. And I have seen very impressive, mind-blowing results in some patients, but not all. So what I tell patients is about 50% of patients will see an increase in their AMH and follicle count, and that could translate into a better IVF outcome, but you don't really know until you try. And I wish we had a better test to tell us if PRP will really help a patient or not. But, I've had patients, let's say they've tried 6 cycles, they're 44 years old and none of the embryos were euploid. And then they do ovarian PRP and I get them their first euploid and then they get pregnant and have a healthy pregnancy. So I feel like before donor egg, because I think oftentimes women are bullied into egg donation at 40 and they're not given options like PRP. I personally feel that PRP should be given to a patient as an option before egg donation if she's not done with her own egg IVF journey.
What causes embryos to stop growing after fertilization?
So a lot of it has to do with genetics. So chromosomal abnormalities. So if an embryo is chromosomally abnormal, it will stop growing just because of that and it will degenerate.
Have you seen results putting patients on metformin who are not diabetic and have no PCOS but show signs of glucose intolerance?
If you have glucose intolerance, there is a role for metformin, even if you don't have a diagnosis like PCOS. Having normal metabolic parameters can certainly help your fertility. If you don't have glucose intolerance, metformin used to be something, 20 years ago, where we thought it was the magic pill. Like we gave it to everyone. We thought it would help with egg quality. We thought it would help the egg quality of women over 40. And unfortunately, that just did not pan out. But if you have glucose intolerance, I would recommend metformin. It could help with your egg quality. But metformin does have side effects. So I often recommend to patients to work with a fertility nutritionist and also to take Ovasitol as a supplement and try that first. And if those things don't work, then you can easily just transition to metformin.
Thank you. And a bit of a related question. How soon after trying to conceive do you need to stop GLPs? Can you take them while trying, but then stop when you get pregnant? And also, and I'm adding this myself, what is your take on GLPs in preparation for fertility treatments in general?
Yeah, so I highly recommend GLP-1s to patients who are open to them. I think they are a magical drug. They can change a patient's life, change how she sees food, improve her mood, decreases inflammation. And there are a lot of different recommendations out there. The general recommendation for a GLP-1 is to stop it 2 months before trying to conceive. That is not the recommendation that I give to my patients. You have to stop it 2 weeks before an egg retrieval because of the anesthesia risks of having food that's maybe still in your stomach. So you have to stop it then. But I have patients restart as soon as they're feeling better after their egg retrieval. I stop their GLP-1 a week before an embryo transfer. And I certainly have patients who I feel very comfortable telling them that you can basically take it up until you have a positive pregnancy test. I predict in the next 5 years, we are actually going to be recommending GLP-1s in pregnancy unless the patient is rapidly losing weight, not able to eat, having nausea, severe constipation. And there are some patients that experience those side effects. I don't recommend starting a GLP-1, for example, right before you're pregnant, because you just don't know how you're going to respond to it. But for patients who have been on it and it's been working really well for them, and let's say they haven't reached their weight loss goals yet, I think it's a really good tool. And I don't have any problem with people stopping it when they find out that they're pregnant personally. But that might not be your doctor's advice. So I would definitely talk to your doctor about it.
Anecdotally, as a therapist, people will sometimes come to me and say, "What do you think about GLP-1s?" And obviously, I'm not going to give them that advice, but I will say I have seen people's personality change after being
Oh,
on it in a great way. They're just much happier.
so much happier. I have a personal journey. I lost 60 pounds on a GLP-1 over 2 years ago. I've kept it off since. I've struggled with my weight for over 46 years, and the GLP-1 changed my life. I was on every single diet that you can imagine. I've had problems with my weight since I was a child.
Wow, that is incredibly open of you to say, and I think everyone appreciates that. We have a question about males here. So for a 37-year-old man with poor semen analysis, less than 1 million total and motile sperm, is there still a realistic chance of natural conception, or would IVF be the only path forward?
Yes, there is not a realistic expectation that you could get pregnant with that sperm count. However, when you have a sperm count like that, you want to ask why. Is it low testosterone? Is it anatomic? Is it genetic? You want to do all the tests first before you try and conceive, before you jump into IVF. You don't want to do IVF and then have someone say, well, maybe we should have done these tests first. There is a rule for drugs like Clomid and Arimidex. These medications can increase a man's sperm count, and I've seen them do it to the point where a couple can get pregnant naturally. There's also a dilated vein on the testicle called a varicocele that can be removed, and about 30% of men who have a sperm count like that could have one. Removing it has about a 75% chance of improving sperm to the point where you might be able to get pregnant naturally. But with that kind of sperm count, you wouldn't expect to be able to get pregnant naturally without assistance.
New comment on duo-stim IVF. My last cycle yielded low blastocysts, and this has been recommended.
Duostim is something I do for patients who are at the point where they're nearing menopause, where I really want to give them a chance to have as many eggs retrieved as possible. So what that means is we're nearing the point where we might not be able to get any eggs soon. So typically what I would do is retrieve an egg. If there's a smaller one, continue to stem, retrieve that egg, and just keep going as long as we can. I don't think in patients with normal ovarian reserve, duostim is a good idea because I think you're much better off waiting, letting your ovaries rest, and then recruiting another set of eggs.
How soon after endometriosis surgery does natural fertility improve?
Pretty immediately. So I tell patients, if you're feeling well and you have a period after surgery, you can start trying. So it literally removes the inflammation. So it's not like it takes 3 months for the inflammation to go away. I mean, once they excise it, it's removed. So it's really important to meet with an excision surgeon, not someone like your OB/GYN who is not skilled and trained to doing excision. They just ablate endometriosis, and that just doesn't help things. It just can make matters worse.
Does gluten, dairy, and alcohol in minimum quantities really affect the implantation process? Should I avoid all of this?
Gluten and dairy, even in moderate quantities, do not impact your fertility. Elimination diets should be avoided. You should eat healthy. You shouldn't shame yourself for eating gluten. And I see so many patients do that. Alcohol, I'm personally alcohol free. It's just how I live. And I had, just a choice that I make for myself. But I don't think that drinking alcohol, light intake, is harmful for fertility at all. Light intake, however, is defined as 4 ounces of alcohol per day. So most Americans, when they drink a little bit more than that. So I remind patients what light intake really is. Because patients will say like, I don't really drink. I have 2 glasses of wine a night. And I'm like, well, that's actually, depending on how big your pour is, that can be quite a lot.
I love that you actually gave specifics on how much, because I get that question too, or people blame themselves because they had a glass of wine at a party before their retrieval and they blame themselves.
Doesn't matter. Won't hurt a thing.
How long should someone continue trying before moving to donor?
The journey is a spiritual one. It's a very emotional one. And I tell patients, don't move to donor until you're excited about it. And if you don't know what I'm saying, you're not excited about it. You have to be really excited about finding your donor. If you're not excited, it's actually going to be really depressing. It's going to be traumatizing. You need to grieve your own DNA first before you can move on and get excited about an egg donor. And I have so many patients, they're like, Aimee, I'm excited now. You were right. I am so ready. Like, I'm excited to bring home this baby. I've moved on from my own eggs. I know that I've either aged out of the process, or I know that I just wasn't born with eggs that can turn into a healthy pregnancy, and I'm ready to move on. So I think that's the point when you know you're ready, is when you're excited. You can maybe do a search, and if you're turned off by it, you just get this icky, creepy feeling like this is not for me. You're not ready yet.
Mhm. Yep. And I'm going to piggyback off that or to say that if you are feeling like another retrieval is going to just put you in a grave, take a break and then see, will you feel relieved if you move to donor? Because I think what often happens is people then just feel this sense of relief when somebody says, would you want to consider donor?
Right. And a lot of times patients think that they're giving up too early. And if you feel like you still have another cycle in you, and if that cycle doesn't work, and you can say, at least I tried one more time and that's important to me, that's one thing to think about. And the other thing, if you do another cycle and you say, I really wish I didn't do that to myself again, then don't do it.
That's great advice. What is your perspective on freezing eggs in your 40s?
I'm trying to think. The oldest egg freezing patient I had that had a healthy embryo, she was 43. And the reason is her husband could not perform. So we had a sperm emergency. We called in the ambulances. No matter what we did, he could not perform that day. I think she almost wanted to murder him. Anyways, so that's the oldest patient. The oldest egg that I've ever frozen was in a 51-year-old. She hadn't met Mr. Right yet. True story. I did fertilize the egg later. It was one egg, and it turned into a blast, but it stopped growing. So we weren't able to biopsy and freeze it. So 43 for me, but depending on your age and the number of eggs you have, I would say don't let anyone bully you out of freezing your eggs. There's still a chance if you're over 40.
I have a follow-up question to that. If you are over 40 and you're freezing your eggs, or just in general freezing your eggs, is it still the same as it used to be where they say embryos are better to freeze than eggs?
Absolutely. And the thing is that there are a lot of reasons why. One of the things I tell people, it can take, 6, 10 eggs, depending on your age, to get a single embryo. So you don't really know what you have until you turn them into embryos. Eggs are not a chance for a baby. Eggs are just a chance for an embryo, which is then a chance for a baby. And then, yes, the survival rate of an egg is lower than the survival rate of an embryo. So an embryo survival rate is around 99.5%. For an egg, it's around 90 to 98%. I mean, you should still be able to get a really good recovery from frozen eggs. But if they're lower quality eggs, that has a lot to do with your age, they sometimes don't survive as well.
I love that you give stats because I get those questions all the time. By the way, I do think that getting a hitman for a reason like your partner failed when he needed to, I think that's maybe legit, actually.
Yeah.
Okay. How do we balance the desire to push ahead every cycle and the need for a mental break?
So I see that struggle in my office all the time, and I can see it in their eyes. And I tell them to take a break. A break is going to be really good for you. Take good care of yourself. Get yourself off these medications. Feel good about your body, about your relationship with yourself, your partner, if you have one. There's nothing bad that's going to happen if we wait a month. That's hard because we hear the ticking clock, especially if we're over 40, and we feel like, oh my gosh, in a month from now or 2 months from now, all my eggs could be gone. That's just really not the case.
I think also when you're debating, should I take a break or not? I think you take the break and I think you do something meaningful in the break. Don't just sit around and just work really hard. Do something, go on a trip, do something to bond with your partner, make something happen. Okay. What can you recommend for older couples trying to conceive without IVF when the female has Hashimoto's?
I mean, Hashimoto's, just make sure your thyroid is under control. That's the most important thing. For patients who are having a hard time with just doing that, I sometimes recommend naltrexone. Low dose naltrexone, or LDN, is a tool that they use, the naturopaths. So they use LDN a lot. I do too. And a lot of patients feel better on it. It may reduce your antithyroid antibody levels. I can't promise that it will to everybody, but that might be a tool for someone to use who is dealing with Hashimoto's, is over 40, and it might just help things along.
So it sounds like too, though, it's not so much the Hashimoto's, it might be that they're older.
That's right. I don't think the Hashimoto's is playing a role if your TSH is well managed.
For a 31-year-old that has been trying to conceive for 4 years with diminished ovarian reserve, polyps, hyperthyroidism, and suspected endometriosis, why is a frozen embryo transfer more important than an egg retrieval? Not sure.
I wouldn't say a frozen embryo transfer is more important than an egg retrieval. An egg retrieval is very important, but I would say going into an embryo transfer, you want to be sure that you've treated the endometriosis, the polyps are gone, and you've done enough IVF cycles for your future family, and that you have enough embryos preserved. So the frozen embryo transfer, you should be working with someone who's very thoughtful and considerate and isn't just going to roll the dice with your embryos and just see what sticks. They should really address the conditions you have before doing a transfer and not say things like endometriosis doesn't matter. People with endometriosis get pregnant all the time. Certainly they do, but when you've had a journey and you already have an egg supply that might not be a renewable resource like in someone else at your age, I think it's important to do enough egg retrieval cycles first before you start your embryo transfer journey.
How do REs calculate the mathematics of a live birth?
For me, it has to do with the quality of the embryo, the day it was frozen, if it's genetically tested or not, and if the patient has other potential pregnancy-threatening conditions. I'll tell that patient up front so that she's aware that she might need more embryos to have a live birth compared to someone who does not with the same quality embryos.
I have a follow-up question. Would you say day 5, day 6 is similar, or and maybe it's
Very
day 7
similar.
that's not great?
Correct. Day 5 to day 6 is very similar because when you're testing embryos, a lot of times people just wait to day 6 because they've already done their work for the day on day 5 by, let's say, 11 a.m. and they want to just give the embryos an extra day so that they can safely biopsy it. And they're not going to do it at like 3 or 4 p.m. So day 5 and day 6 implantation rates are pretty much the same. What I do for a patient is I take the day 7 quality and then I reduce it by 15%. And that's the implantation rate that I quote her based on what the implantation rate would be on day 5 or day 6. I reduce it by 15%. And then I tell her what the chances would be with that day 7 embryo.
And love the numbers. Is a baseline ultrasound always needed before an IUI cycle?
I offer a baseline to every patient, but I do not require it. Patients are busy. If they are especially not coming off a previous treatment cycle, the likelihood of having a cyst carry over into that IUI cycle is really low. If I've never met a patient before in person, I do want to see them so I can dose the medications appropriately. But I offer patients a baseline by cycle day 3 just to make sure there isn't a cyst, but is not a requirement at all and shouldn't be.
What causes failed implantation after having an excellent embryo graded 6BB that was tested as genetically normal?
So 6BB is a good embryo, but I wouldn't use the word excellent. So a 6BB, if it's a day 6, has about a 55% chance of turning into a healthy pregnancy. So that grade to me says if it didn't work, it's most likely embryo driven. If it was, let's say, a 6AA, that's a different story. It still could be a uterine factor, even with a 6BB. But embryos have to activate certain genes in order to implant. If those genes aren't activated, it's not going to. And we don't have a way to measure those genes before we transfer an embryo. And we can't, I would love to send in a tiny little camera in with the embryo so we can actually watch and see what it does. But we're not able to do that.
Can you discuss alternative medicine routes to increase my chances?
Alternative medicine routes, so supplementation, CoQ10, if we're dealing with egg quality, resveratrol, True Niagen, melatonin at night. I also recommend working with a fertility nutritionist. I also ask patients to consider doing low-level light therapy, which is red light therapy. And then if a patient will enjoy doing acupuncture, I say only go to acupuncture if you look forward to it. If you're like, can't wait to, go to my acupuncture appointment. Otherwise, I say, forget about it. And there's obviously other things, mindfulness, meditation practices. Yoga is also another practice. I love, what is it called? Sound. I can't think of it right now.
Sound healing or sound bath?
Sound healing, sound bath. Oh my God, those are so amazing. So anything that will just make you feel more peaceful can't hurt your fertility.
So you're having 2 categories of supplementation or some kind of
Supplementation's a device.
right, but then there's the mental, like stress-free.
Absolutely. Focusing on your sleep, making sure you're exercising enough. Those are all really important things to address if you're looking at the patient as a whole.
And I'm going to follow up with the alternative medicine question that probably some people are asking. If I cannot do it all because of finances or whatever, which should I prioritize?
I mean, the supplements, CoQ10,
Okay.
True Niagen. If you're going to buy 2 things, that's it. And then, you don't need a gym membership. Sneakers, 8,000 steps per day at least. Buy 5-pound weights from Target. Do them by your desk. Have a standing desk. I have a standing desk here. I go up and down. Try and stand at least 10 minutes for every 50 that you're sitting. Or 60 that, every hour, stand up for 10. Just try to avoid being super sedentary. I asked patients, how many steps did you take a day today? She's like, typically it's around 2,000. I'm like, how are you still alive? You got to move your body. Pregnancy is like a marathon. You got to train for it.
I am 100% on board with that. I am very big proponent of fitness and especially how much it helps your mental health. What is the most important thing to do before and after your transfer? Also, any tips for a modified natural?
Yeah. So before and after the transfers, make sure your cavity evaluation has been done and you aren't missing anything like a misdiagnosis of scar tissue, endometrial polyps, fibroids that need to be removed. Unfortunately, I see that happen too infrequently. So just make sure that you've had a recent cavity evaluation. I have a list of preconception labs that I do beforehand too, like checking your thyroid, your vitamin D, making sure you're not anemic, making sure your immunizations are up to date to measles, mumps, rubella, for example, chickenpox if you haven't done that. And then I always offer patients implantation testing to look at the microbiome. There are lots of ways of doing that. There's an endometrial biopsy and there are also home tests that you can get like Microgen DX, and you can just search for vaginal product. After the transfer, I monitor hormone levels because the last thing I would want is someone to have a negative pregnancy test and then wonder, did I have enough progesterone? So I do check progesterones after transfer. I check progesterone with their HCG levels just so that if it doesn't work, they're not going to have that question. I tell patients to rest for 2 days after the transfer. Rest doesn't mean being in bed. It just means not doing anything that's either physically or mentally strenuous for those 2 days. Some patients also choose to do acupuncture.
Would you recommend movement in some forms like short walks
Yeah,
and stuff?
absolutely. Strolling. And I kind of show patients what my strolling looks like and makes them laugh. Maybe they're embarrassed for me. It's that way.
Okay, when should I seek another physician?
When you're asking that question.
Good.
So I think sometimes just bouncing what the clinic that you're working with is recommending for you is a good, it's just nice to have someone else say you're on the right path. Like, this is exactly what I would do for you. And then also, like, they might bring up something that your other doctor didn't mention. You still want to work with the other doctor, but now you're more informed. So I do a lot of second, third, fourth opinion consults. And I say, come to me and I'll just kind of share with you what I would do in your situation. Then you can take that information. You're more empowered going back to your doctor. So it doesn't mean you're going to split up with your doctor. It just means now you're a more informed patient and you just know more about your situation and what you need to ask for.
I have two final questions for you, and they're a little lighter and a little personal. If you had to swap careers for a month and you were already amazing at it, what would you choose?
I would be an EDM DJ. I would be on stage with Diplo, and I would be on that stage around the world in the sphere, just making people happy through music. So we run soft EDM in my office here during the day, and I have EDM playing in the operating room, EDM in the transfer room. Patients get their choice of music in the transfer room, and if they can't decide, then I'll choose.
Like a party in there.
It is every day.
Okay. Do you go to bed with your email inbox at 0, or are you one of those people with thousands of unread messages in that icon corner?
0. I can't go to sleep at night until I've replied to every patient. And sometimes patients send me it's like a novel. It's like 30 questions with A, B, and C, but I'll at least reply to them and say, I want you to know I've received your email. I don't have time right now to answer it. Let's set up a call, or I'm going to reply to you tomorrow, but at least they know it's been received and that they will hear from me.
You are an icon as a fertility doctor in that sense, I have to say. And how can people book a consultation with you?
Through my website, draimee.org. You click on schedule a consult. There's a contact form you fill out. Once you fill it out, my new patient coordinators, I have 3, they're fabulous, and they'll reach out to you and get something scheduled.
Dr. Aimee, we are so grateful for your time. Thank you so much for coming on tonight.
I appreciate all you guys. Talk to you later.
Thank you.